So today's topic of discussion is anterior crossbite. So today we will talk about in depth what are the definition, what is the etiology of the anterior crossbite, why we treat a patient of the anterior crossbite, and more importantly, what are the factors that we consider before making any decision for the correction of the crossbite. What are different appliances we use for the correction of the anterior crossbite, and what variables we consider for making decision regarding the choice of the appliance in any case of the anterior crossbite. And these are the outline of the lecture we will be talking about in this. So anterior crossbite is a malocclusion in which you have one or more upper incisors in lingual occlusion. Words, one or more lower incisors could be labial to the upper incisors in the anterior crossbite. This we call as a anterior crossbite. At least one or more tooth should be involved. There is a possibility that all of the incisors could be involved. There is a possibility even one tooth could be involved. One of the most common causes of the anterior crossbite is the lack of space for the proper eruption of the any of the incisors. For example, as you can see in this case, you can see two of the incisors are in crossbite, and one of the more important and most common reason for the anterior crossbite is the lack of provision of adequate space for the proper eruption of the incisors. And most commonly you see the upper lateral incisors in the crossbite. As you know that the permanent dental lamina is lingual or palatal tuberous and primary incisors. So when the permanent teeth erupt, they come forward into their proper position. And if they are having a lot of crowding and it's not allowing and letting the lateral incisors to come into this proper position, then this could lead to the anterior crossbite. And this is one of the most important and common reason for the anterior crossbite. Moving on to the retained primary teeth, because of the primary teeth are retained, as you can see in this here in this case as well, you can see over there a primary canine. So because of the primary canine, you can see there is a crowding, and this has deflected and not allowed the lateral incisors to come to its proper position. So that is leading to the crossbite on the incisors over there. And the major cause is here, uh, other than the crowding, which is caused by the retained primary teeth, is the retained primary teeth has deflected the upper incisors palatally, leading to the development of the anterior crossbite. Moving on, in a similar way as the retained primary teeth and crowding not allow the upper incisors to come to its proper position, in a similar way the supernumerate teeth could cause the upper incisors to erupt palatally. In a similar way, the ectopic eruption or a lingual eruptive pathway could be the etiology of the anterior crossbite. Moving on, there could be the skeletal reason as well. Obviously, we have discussed about what are the dental reasons for the anterior crossbite. The skeletal cause of the anterior crossbite, if the maxilla itself as a whole is deficient and posteriorly positioned, then all of the incisors would be in a reverse overjet. As you can see in this photograph, you can see the maxilla is posteriorly positioned and mandible is ahead of the maxilla. As the whole of the jaw is not in proper position because of the deficient growth or any other reason, if the maxilla as a whole is posteriorly positioned, then all of the teeth which are attached with this particular bone is in the reverse overjet. As you can see in this picture as well, okay, all the incisors including the canine are in the reverse overjet or in the reverse position. The lower incisors are ahead of this. So here is the very important clue which you can use for diagnosis of the anterior crossbite, that if the more number of teeth are involved in the anterior crossbite, there are more chances that the cause of the malocclusion or the anterior crossbite is of skeletal origin. If you see the upper incisors are proclined, as you can see in this patient as well, okay, as you see in this picture, all of the teeth are involved, are in crossbite, even up to the canine. The other important variable that you see in the skeletal region of the anterior crossbite is the proclination of the upper incisors and retroclination of the lower incisors. In the skeletal region of the anterior crossbite, you would be seeing that all of the teeth are involved in the crossbite. Secondly, you would see the proclination of the upper incisors as well. However, in the case of the dental region of the anterior crossbite, you would be observing that the maxilla and mandible are in appropriate position with respect to each other, and you would be observing lesser number of teeth involved in the crossbite, 1 or 2 teeth may be involved in the crossbite, and secondly, you would be observing that the upper incisors would have retroclined, because in order to go into the anterior crossbite, the incisors may go retroclined. So these are the specific characters which you can see in this photograph. Uh, Number of teeth are greater, all incisors are involved, and the incisors are proclined. These are the hallmark and signature mark of the anterior crossbite of skeletal region. Moving on to there could be a possibility of cleft lip and palate. As you know, okay, with the cleft lip and palate, if the palate is repaired surgically, then it would not allow the proper development of the nasomaxillary complex and whole of the maxilla, as we discussed in the skeletal region. All of the teeth would be involved, and the maxilla would be in a retro position as compared to the lower jaw. Secondly, with the surgery of the lip, due to the lot of scarring of the lip, the upper incisors would be retroclined in the patient of the cleft lip and palate. So what kind of the problem you can observe in the patient of the anterior crossbite? And these problem could be the rationale for the treatment of anterior crossbite. Number one is the periodontal problem. As you can see and appreciate from this photograph as well, that the clinical crown length of this incisors is greater as compared and relative to the adjacent teeth. What is happening? The upper incisors is pushing the lower incisors labally, and due to this malocclusion, one of the biggest and sometimes irreversible as well, because the upper incisors is pushing the lower incisors labally. Because of this malocclusion, yeah, malrelationship of the incisors, they are occluding in a way that upper incisors is pushing the lower incisors to come out of its alveolar housing. As the incisors are coming out of its alveolar housing, then it is pushing and moving out of the alveolar house and alveolar bone, so it may lose the attachment apparatus around it, and this would lead to the increased clinical height of the lower incisors. As you see, the incisors are in abnormal or in the reverse overjet or reverse position. There could be a possibility of damage of the incisal edges, or if the whole of the incisors is overlap, you could see the attrition on the incisors, and this is obviously an irreversible damage. You then definitely you have to repair this damage with some composite buildup. The mandibular displacement could be another problem of the anterior crossbite, because if the patient is occluding his mandible and you are not having a proper relationship or any kind of dental interference on the centric relation, and if there is a contact or deflecting contact on the centric relation, the patient may move his mandible laterally or anteriorly to avoid that dental interference, and this may lead to the displacement of the mandible. And if the displacement of the mandible is in the asymmetric or deviating the mandible left or right, you may encounter the development of the facial asymmetry, because this dental interference, because of the anterior crossbite on the centric relation, is sometimes is acting as a endogenous functional appliance. You know, what does the functional appliance do? The functional appliance keep the mandible forward in a particular position. So this kind of dental interface, because of the anterior crossbite, if the patient is keeping this position for many a times, then this may lead to development of the facial asymmetry, because this dental interference may be acting as a endogenous functional appliance. Moving on to the one tooth is in the crossbite, that it will be out of the uh, alignment, and in some patients, the anterior crossbite as the patient may have displacement of the mandible due to the anterior crossbite. So in some susceptible patient, this could be a predisposing factor. I'm repeating my two words, please note my two words, that in this anterior crossbite and displacement of the mandible because of this anterior crossbite could be a predisposing factor. I said predisposing factor in some susceptible patient, not in all the patients. So these are the problem which you can see crossbite. So what do you understand that why we do treat the patient of the anterior crossbite? Because of the problem that we have discussed previously. So the rationale of treatment of anterior crossbite is would be definitely all of the problem we can avoid, and we can avoid by doing the treatment of the anterior crossbite. If you look at this patient carefully, then one of the most important and chief complaint you can see in this patient is that the patient is not having a proper smile, and doing the treatment, orthodontic treatment of this patient, the smile would be be improved a lot by having the treatment of the anterior crossbite, because if one or two incisors are in the anterior crossbite, then this would be you would be feeling like the incisors are absolutely missing from the smile. So by doing the treatment of these kind of the patient, you would be and restoring the smile. So aesthetic is the reason for doing the treatment. And in some, as I said, in some susceptible patient, the anterior crossbite could be a predisposing factor toward the development of the anterior of the TMD. This may lead to the development of the asymmetric growth of the mandible. If the patient is occluding his mandible from the rest position, and if we encounter deflecting contact and or any kind of the abnormal tooth contact on the centricillation, then in order to avoid this dental interference, the patient would be moving his mandible maybe anteriorly, maybe laterally. And if it start moving the mandible laterally due to the dental interference on the centricillation, because of this malocclusion or anterior crossbite, then this may lead to the development of the asymmetric growth of the mandible. How? Because as you know, how does the functional appliances work? The functional appliances work by keeping the mandible in a particular forward position. The patient always keep the mandible forward whenever they have the functional appliance in situ. So if for some reasons any tooth relationship is forcing the mandible anteriorly, then it would be start acting as an endogenous functional appliance. Okay. Moving on, okay, if this abnormal tooth contact due to the anterior crossbite, if it is keeping the mandible asymmetrically, or the patient is forced to move the mandible laterally because of the dental interference. So in order to avoid the dental interference on the centricillation, it will be keeping the mandible into the bite of the maximal comfort. So if the patient is moving the mandible laterally or in any direction, then this could lead to the development of the asymmetric growth of the mandible. So this is a very important rationale for doing the treatment and the early stages and early growth. Another reason is that this could lead to the disaster in the periodontal health, because upper incisors would be pushing and forcing the lower incisors out of their alveolar housing. So when the lower incisors are pushed from the lingual aspect to go out of its alveolar housing and losing all of its attachment, then you could be observing, as you can see in this patient, that the clinical crown height of this tooth is increased as compared to its adjacent teeth. So this is one of the reasons for doing the treatment of this kind of the patient. So there are many variables that you will be considering before making the decision for the treatment of the anterior crossbite. As I said, the anterior crossbite could be of the skeletal region and could be of the dental region. So skeletal, first of all, you have to differentiate between the skeletal versus dental region of the anterior crossbite. What you will see in the skeletal region, you'll be observing the deficient maxilla, and you could be having a retrosive profile in the middle of the face, and you would be observing a greater number of teeth would be involved in the anterior crossbite. All of the incisors could be involved in the anterior crossbite. Thirdly, you would be observing, because the maxilla is deficient, this would be leading to the compensation of the upper incisors in the form of the proclination of the upper incisors. So in the skeletal region of the anterior crossbite, you will be observing the deficient maxilla, retrosive profile. You would be observing all of the incisors in the crossbite, and you will be observing the proclination of the incisors. However, in the dental region of the anterior crossbite, you will be observing you may have normally the class 1 skeletal relationship. The maxilla is appropriately positioned, and one or any of the incisors would be retrocline in order to go into the anterior crossbite relationship. So in the dental region of the anterior crossbite, you would be having appropriate position of the maxilla. You would be observing the retrocline upper incisors that would be in the crossbite. Okay, the upper incisors of the dental region would be retroclined, and you would be observing one or two teeth maybe in the crossbite of the dental region. This maybe three more, like in most commonly you would be observing one or two teeth in the crossbite. So what I was talking about, the third and possibility of the anterior crossbite is of the functional region. You may encounter a kind of a situation in which the maxilla and mandible are normal, the teeth are normally positioned, but the anterior crossbite you would be observing on the occlusion. The anterior crossbite on the occlusion, this because the patient is keeping the mandible in a forward position. it is just because the mandible is keeping the patient is keeping the mandible in a forward position. The first thing that you will be doing in the diagnosis of the anterior crossbite, that you will differentiate it from the skeletal dental region, and you will be observing, is there any displacement in the anterior crossbite or not. For example, if there is displacement, then this anterior crossbite would be very easy for you to treat. The first thing that you will check in this patient of the crossbite, you will be observing what is the relationship of the teeth on the centric relation, and is the patient is keeping mandible for the forward or anteriorly or not. The second important factor you will be observing for the decision making of anterior crossbite is how many teeth are involved in the anterior crossbite. If all of the teeth are involved in the anterior crossbite, this could be of the skeletal region, and this is much more challenging to treat. If all of the teeth are in the crossbite, in simple concept, this is very much challenging to treat, and if one tooth is involved, this is the least challenging case to treat. So the involvement of number of teeth is important variable for decision making. Moving on to the age of the patient, as we know, we have ruled out the displacement, we have ruled out what is the what is exactly the cause of the anterior crossbite. Is it because of the skeletal region or dental region? Then moving on, okay, if we have a skeletal component of the involvement, then a very important factor is the age of the patient. As we know, if the maxilla is deficient and the anterior crossbite is of the skeletal region, then your goal would be orthopedically advancement of the maxilla. So what you will be doing, you be protecting the nasomaxillary complex forward by some orthopedic appliance. Normally we give face mask. So we have a limitation of the growth. What is happening, the nasomaxillary complex of the maxilla is attached posteriorly and superiorly by the sutures, and with every passing day the sutures are getting more and more fused and obliterated. By the age 7, 8, 9 years, with every passing day, the obliteration of the suture is increasing. So the skeletal effect you will be observing before the 8 years would be more, and after 10 years you will be just proclining the upper incisors and upper teeth with even with the orthopedic appliances as a side effect. If in simple word, if the maxilla by the suture which are posterior and superior suture by which the maxilla is attached posteriorly and superiorly, if they get fused due to the maturation by the growth, this would be very challenging for you to advance the nasomaxillary complex by the orthopedic appliances. So moving on, what we have discussed so far, first of all, we will see is there any component of the displacement. What is the cause of the anterior crossbite? Is it because of the skeletal region or the dental region? How many number of teeth are involved? And is the crossbite is of the skeletal region? Can we treat this patient with some orthopedic appliances or not? This we will be considering in any patient. And after the age of 10 years, the simple concept that you can, the take home message this, that you cannot apply face mask for the protection of the maxilla after CVM2, because after the age of 10 years, the sutures by which the maxilla is attached posteriorly and superiorly, they would get fused. So not be left with the good opportunity of protecting the nasomaxillary complex forward by the orthopedic appliance, which are the face masks. So another important variable for making decision for the patient of the anterior crossbite is the internal motivation of the patient. Because if you are going to apply and giving a kind of a removable appliance for the patient of the anterior crossbite, the patient, especially the patient of the anterior crossbite, is very important to treat, because this is a kind of an orthodontic emergency. Anterior crossbite is basically an orthodontic emergency. So this is the responsibility of the clinician to convince the family and convince the patient for the optimum position. And one of the very important variable is the internal motivation of the patient, because if you are dependent on the removable appliance, and as a rule of thumb, the success of any removable appliance is dependent upon the compliance of the patient. If the patient is wearing the appliance would work, and if the patient is not internally motivated a lot, and then the success and the outcome of the removable appliance would be highly questionable. So this factor is very important for making decision whether you're going to be treating this patient with the removable appliance or the fixed appliance. Moving on to the next factor is the skeletal versus dental crossbite. As we have discussed so far, if the crossbite is of the skeletal region, then you would be observing three more important variables. You would be seeing concave profile, you would be observing retrognathic maxilla, and you would be seeing many of the teeth are involved. The crossbite of the dental region, you will be observing retroclined upper incisors, because if the maxilla is normal, and the teeth are in crossbite, then upper incisor would be retroclined. If the maxilla is deficient and it is posteriorly positioned, then you would be seeing all of the teeth are involved in the anterior crossbite, and you would be observing the proclination of the upper incisors in the form of the compensation, because the tongue will be pushing the upper incisor forward. So in the patient of the anterior crossbite of the skeletal region, you would be observing deficient maxilla, retrosive profile, uh, the, all of the incisors in the crossbite, and some proclination of the upper incisors. Okay. Okay. In a similar way, you can observe all of the incisors are in the crossbite, and the upper incisors seem proclined. Whereas if you consider the dental crossbite, you can see over there the patient is having mild class 2. It's a class 2 patient. As you can see from the profile analysis of the patient, you would be observing that the patient is of the class 2 skeletal region. And what the difference you can see by comparing from the previous patient is that the position of the maxilla, the profile of the patient, and you would be observing the inclination of the incisors. As you can see in this patient, this is a slightly severe patient in which two of the incisors are involved in the crossbite. The central incisor and the lateral incisor are involved in the crossbite. And you see the skeletal relationship is class 2, and anterior incisors are in the crossbite. So this is because of the inclination. Somehow the upper incisors is deflected palatally, and can you compare the inclination of this incisors and the inclination of the incisors in this case? This is of skeletal region, and this is of dental region, in which you see the retroclination of the incisors. So moving on, you will see the overbite at the start of the treatment and at the end of the treatment. So a very important factor for making the decision of anterior crossbite is the overbite at the start of treatment. For example, if you consider this case in depth, you would be observing that all of the incisors, even the upper incisors, is not visible in the frontal intraoral photograph. So this is a huge amount of the overbite is present at the start of the treatment. So this is a bit challenging case as compared to the kind of a crossbite in which 1 or 2 or 3 millimeter are involved. So this tells you about the complexity level of the anterior crossbite. And the second important variable is that how much is the overbite at the end of the treatment. If at the end of the treatment the overbite is good, this would be having a very good prognosis in the follow-up, because the overbite will be acting as a retainer, and this will not allow the upper incisors to go back into the crossbite. So overbite at the start of the treatment is telling you about the challenging that you can see in this patient during the treatment, and overbite at the end of the treatment is something good, because the increased overbite at the end of the treatment after the correction of the anterior crossbite is acting as a retainer, and this will not allow the upper incisor to go back to its original position. So the next step is, for making decision of the position of the anterior crossbite, is the bodily tooth movement is required for the correction of the anterior crossbite, or a tipping movement is required. As we know, the removable appliance can only tip the incisors. So what is the initial inclination of the upper incisors who are in the crossbite? This is a very important variable for treatment planning point of view, and as far as for the selection of the appliances, because if the upper incisors are retroclined, then you may be able to treat this patient with the removable appliance. But if a bodily tooth movement is required for the correction of the anterior crossbite, then this you cannot use any removable appliance. So the inclination of the teeth are very important for the choice of selection of the appliance. Either you're going to use the remove appliance or the fixed appliance, depend upon the initial inclination of the teeth. So, and the other important is the arch length discrepancy. Arch length discrepancy is very important. For example, if you're going to correct the position patient of the anterior crossbite, are you giving them appropriate and the optimal space in the arch for the correction of the anterior crossbite or not? For example, if you look at this patient, you can easily bring the upper incisor forward after the extraction of the primary teeth into its proper position. But if you do not providing optimum space in the arch for bringing the tooth which is in the crossbite into the alignment, you have to give optimum space for the correction of the anterior crossbite. First of all, what I always treat in the fixed appliances, I create a space for the lateral incisors or any tooth in the crossbite, then you have to bring the tooth forward. So arch length discrepancy is a very important variable for making decision for the correction of the anterior crossbite, because first you have to give space and generate space somehow by stripping or by moving the canine distally by some extraction, or by one way or other. Any way you can use for the generation of the caries, depend upon many other variables. But the first more important factor for the correction of the anterior crossbite is the development of the appropriate space that is optimally required for the correction of the anterior crossbite. So moving on, another variable is the reciprocal movement of the anterior. If you see the lower incisors are procline, and if you see the upper incisors retrocline, this is slightly easier for you, because with the reciprocal movement of the lower incisors, this would be easier for you to treat. For example, if you have procline lower incisors and upper incisor retrocline, then by the reciprocal movement of the lower incisors, it would be slightly more easier for you to make decision for the choice of the appliance and for the treatment planning point of view. So the last factor you will consider is there any need for the buccal capping or not, because this opinion is dependent upon the initial crossbite. You have to give clearance for the correction of the you have to give clearance for the relief of the dental interference. You cannot bring any tooth in the which is in the crossbite into its proper position until and unless you are observing and having dental interference. So in order to avoid the dental interference, if you are using the removable appliance, you have to plan a kind of a removable appliance in which you would be giving the buccal capping. So this buccal capping will increase the bite and give some relief for the correction of the anterior crossbite, because the main objective of this buccal capping or this buccal bite block is the removal of the dental interference that you may observe or while you're doing the correction of the anterior crossbite, while you are actually bringing the incisor which is in the crossbite to its appropriate position. So this the do you need any buccal capping or not depend upon the initial overbite. For example, if I ask you the question, because do you need any kind of the bite block for this patient or not? Obviously, you cannot bring the upper incisors to its to its optimal position without giving any bite block. Okay, so there are many approaches and treatment modalities for the correction of the anterior crossbite. This could be a remove appliance, could be fixed appliances, orthopedic appliances, or maybe sometimes selective grinding of the baby canines for the relief of the dental interference. So there are many approaches for the correction of the anterior crossbite depending on the diagnostic. So after, as we have discussed so far, what are the different variables that we will be considering for making decision of the choice of the appliance, we can use the remove appliance for the patient. So the variable that you will observing this patient is if this crossbite is of the skeletal region or dental region. Because, for example, the removable appliance would be the best appliance if one or two teeth are involved, and in which the only tilting movement would be required. So the axial inclination of the teeth, which is in the crossbite, is the key variable for the choice of the appliance. If you want to treat the patient of the if you want to treat any patient having the anterior crossbite with any removable appliance, you have to have a compliant patient. You have to have teeth in which you need only the tilting movement. You need only the tilting movement, because the upper removable appliance can only produce the tilting or some tipping movement. So if you want to bring the upper incisor by bodily, you cannot use removable lines. So the removable lines are useful and workable where the patient is compliant and where you need only tipping movement. And you can do with some kind of spring that you can, as you can see over there, the buccal spring. You can use double cantilever spring or any kind of a screw plate in which you're just tightening the screw and this pushing the upper incisors into its proper position. Moving on, the success factor for the upper removable appliance for the correction of the anterior crossbite, the more important factor for any removable appliance is the compliance of the patient. You cannot have a good treatment outcome with any kind of the removable appliance if the patient is not compliant with the wear of the appliance. So you have to have a patient who understand the need of the treatment and who understand that this treatment is for you, not on you. this treatment is for you, not on you. So the patient should be compliant for the success of the upper removal plans. Secondly, you have to select the patient for treating with the removal plans who need only tilting or the tipping movement. You cannot produce a bodily tooth movement with the removable plans. So you select a patient in which only the tilting or tipping movement is required. So uh, with the upper removal plans, you can just tip the incisors forward. Moving on, the anteroposterior position of the incisor in the crossbite, as you can see in this patient as well, okay, here the overjet is of few millimeter. So with the upper removal lines, you can produce a kind of a movement in which the crossbite need a mild movement of the teeth or only the tipping movement of the teeth. If the overbite is huge, you need kind of body tooth movement, and you cannot produce a huge amount of tooth movement with the upper removable plines. Okay, so upper remove, the very important factor and variable for the success of the any removable blinds is the amount of the reverse overjet. The reverse overjet should be very mild and very optimum, which could be correctable with just the tipping movement of the upper incisors. So the degree or and the position of the upper incisors before the start of the treatment is a very important variable for the success of the and removable blinds. So another very basic principle for the remove lines for the correction of the interior crossbite is the amount of the space. If you do not providing adequate space, then what if I'm just pushing and giving any kind of force from the palatal aspect by finger spring or by screw or by one or another mean, if the teeth is in the crowding and you do not have optimum space in front of it for the alignment, then this force would be dissipating and transferring to the adjacent teeth. So the basic principles that with for the removable blinds, you have to have optimum space for in which the retroclined teeth can move forward into its optimal position. So and there should be no dental interference in the path of tooth movement, because if you are having a jiggling kind of tooth movement, this may lead to the development of the root absorption as well, and a very poor outcome. Maybe you won't be able to correct the interior crossbite if you are having dental interference. Moving on to the treatment modalities. One treatment modality we have talked about the removable lines, and the other treatment could be even selective grinding of the premature contact. What does it mean? Because the patient is keeping mandible in a proper or in the anteriorly displaced position because of the premature contact, then the removal of the premature contact, or maybe sometime the extraction of the opposing primary teeth. I said the extraction of the opposing primary teeth could be a treatment modality for the correction of the anterior crossbite, provided and the anterior crossbite is because of the premature contact. So the selective grinding of the primary tooth is carried out, or maybe you can extract the primary tooth. The fixed appliances can be used in the early treatment of the interior crossbite, and obviously the 2x4 appliance means that you have two molars on which you are going to put the band or tube, and you have four incisors for the correction of the interior crossbite. So the fixed appliances is used where you need where the compliance is slightly questionable and where the body tooth movement is required. So you may treat any crossbite of the skeletal region by some functional appliances or by some orthopedic appliances, because if functional appliances may work on the mandible, or this may work, or the orthopedic appliances, which and you can use the face mask for the protection of the maxilla in a proper position. You may use the Frankel 3 for the class 3 growing patients. This will remove the dental interference, and this will keep the mandible in a proper position. This may slightly, by stretching the periosteum, this may lead to slight development on the bone, on the sulcuses, and this may lead to the development of the downward backward rotation of the mandible. These are the mode of action of the FR3. Basically the functional appliance in the class 3 patient keep the first of all, it remove all the dental interference, because by the and this the keep the mandible in a downward and backward position. So by the rotation of the mandible, this remove the by the downward backward rotation of the mandible, it will lead to the development of the correction of the anterior crossbite, and this have some dental liver effects as well. So you can use chin cap, is obsolete now. because the evidence, and you can use the face mask. This is very evidence-based practice, and this you can use before the age of 10 years. The best age is a skeletal. The best skeletal age for the treatment with the face mask is the CVM2, and in this treatment modality, this is reserved for the treatment of the anterior crossbite of skeletal region, and this you will be protecting the nasomaxillary complex in a forward position. Moving on to the retention protocol, as you know, the overbite, the amount and the degree of the overbite is basically the retainer. Why you don't need retainer in this anterior crossbite after the correction of the anterior crossbite? Because the lower incisors is keeping uh, and the upper incisors in a retained in retake, because the lower incisors would be keeping the upper incisors in appropriate position. It does not let the upper incisors go back to its original position because of the dental interference uh, of the normal occlusion.